Start and welcome everyone to today's forum. We have a long day because we have the forum this morning and early afternoon. Then we have the gala this evening, where the prizes, the pre-Galien prizes, with a new twist this year in that we're having the annual prizes announced, followed by the discovery of the decade. And that was a novel idea from Bruno, and it's a good one because it allows one to look back what has happened over a decade, and you'll be startled when you see the list of candidates that were the winners year by year, because it gives you some feeling for the progress in biomedical sciences and what the industry that we represent can accomplish, and it's I say it's pretty terrific, and I congratulate all the people who are into it and doing it now. This morning we're going to start with a discussion of diabetes mellitus and cerebral vascular risk. This is going to be moderated by Bengt Samuelsson, and who has assembled a rather terrific group of speakers. And then you'll hear from them in a moment. But let me just say a word about Bengt, whom I have known for many, many years, since the two of us were young researchers. He made it big. Got the Nobel Prize in 1982 with his work on prostaglandins. And he has been I would guess, the strongest pillar at the Karolinska for many, many years. He headed the institute. At one time, he was the dean of the medical school. He was also the head of the chemistry department, and he was a wonderful scientist throughout his career, still is, and he has been able to continue very much involved at the Nobel Foundation, which he chaired. So he has done. He's been at almost every most senior position in Swedish science, and so it's wonderful to have Bengt here. And Bengt, I will ask you to come up now and lead this interesting session. Thanks.
Thank you, Roy, for your kind introduction. Yes, we have an interesting session on diabetes and diabetes mellitus and cardiovascular risk. The rapidly emerging diabetes pandemic is one of the most challenging non-communicable disease threats to public health in the 21st century. More than 450 million people worldwide have type 2 diabetes, and most of which will die from cardiovascular disease. People with type 2 diabetes have a roughly double risk of cardiovascular disease compared with people without diabetes. So a major need exists for evidence-based type 2 diabetes treatment strategies. However, clinical research reported during just the last year suggests that interference with this metabolic condition in new ways may be a solution. And we have 4 speakers here. And before I introduce them, I should say that we are very indebted to Dr. Rydén for organizing this panel. The speakers are all well known for their important contributions to the field. I will discuss recent research that has a potential for leading to breakthroughs in the management of patients with type 2 diabetes. Maybe we are in for a paradigm shift. So maybe you could come up on the podium so I can introduce you. We have Professor Rydén next to me. He is a senior professor of cardiology at the Karolinska Institute of Stockholm, Sweden. Specializes in internal medicine and cardiology. Professor Rydén was the president of the Swedish Cardiac Society and chaired the scientific board of the Swedish Heart-Lung Foundation. He was the president of the European Society of Cardiology and has served on the board of the World Heart Federation. Professor Rydén chaired the task forces that prepared for 2007 and 2013 ESC and EASD guidelines for diabetes and cardiovascular disease. And next is Daniel Drucker, is professor of medicine in the Department of Medicine at the University of Toronto and a senior scientist at the Lunenfeld-Tanenbaum Research Institute at Mount Sinai Hospital in Toronto. Daniel Drucker, who started his career as a clinical endocrinologist, is internationally well known for his studies identifying fundamental aspects of gut hormone action. His research supported the development of 2 new drug therapies for type 2 diabetes, glucagon-like peptide-1 receptor agonists and dipeptidase 4 inhibitors. And the next one is Michael Mark, who is a vice president and global head of cardiometabolic disease research at Boehringer Ingelheim in Germany. And his role, he's responsible for the research and development of innovative treatments for cardiovascular and metabolic diseases, including obesity, NASH, and diabetic microvascular complications. Michael Mark pioneered the discovery of the DPP-4 inhibitor linagliptin and was instrumental in the initiation of the preclinical work for the Sglt2 inhibitor, Jardiance, both compounds globally launched and marketed. And last but not least, we have Bernard Zinman. He's a professor of medicine, also at the University of Toronto, and senior scientist at the Lunenfeld-Tanenbaum Research Institute, Mount Sinai Hospital, and director of the Leadership Sinai Center for Diabetes. His main research interests include the long-term complications of diabetes, the development of new therapies for type 1 and type 2 diabetes, and studies directed at the prevention of diabetes. He's the vice chair for the Diabetes Control and Complications Trial, Epidemiology of Diabetes Interventions and Complications. I think that's about it. And I think we will start the session with Professor Rydén, who will give an overview of the development in this field. Please, Mr. Rydén.
Try to get out here. Yeah, thank you very much for the introduction, and thank you also for giving me the pleasure to participate in this very important interesting and advanced session that the Galien Foundation organizes annually. So it is indeed an honor to stand here and talk to you. My task today is to give a background to the coming speakers. These are my conflicts of interest. And I want to do that giving you an historical perspective, look at the impact of glucose-lowering drugs on cardiovascular disease risk, then safety of glucose-lowering drugs, contemporary trials, and finally, is there any hope by the horizon? And with that, I will give over to the following speakers. So let's start here. Let's start back here. This is the very first patient who got a glucose-lowering drug and survived. It's actually Leonard Thompson, who got injection of a pancreatic extract in Canada by those who detected that. He lived until the age of 27 and died by pneumonia, which also was a diabetes complication, of course. And as you can see here, this is the very, very first report on a glucose-lowering drug used with success, a handwritten manuscript and the very first publication, which resulted in a Nobel Prize to these two people, Frederick Banting and John James MacLeod. In principle, I think it was easier before. They had a few patients, one paper, and the Nobel Prize was harvested. Today, a trial contains maybe in between 5,000 and 20,000 people and would never ever give a Nobel Prize, although it is innovative. So it was perhaps in some way easier before. Diabetes by that time was actually not at all linked to cardiovascular disorders because it ended up like this rather soon. So people did not live long enough to develop the cardiovascular disease, which presently is the most threatening thing for them. We have microvascular, eye, kidney, and macrovascular, legs, heart diseases, which afflicts, and then a number of others. And you have to have your diabetes or pre-diabetic conditions before a number of years until this is a manifestation. But it became obvious when they survived. So what then is the impact of glucose-lowering drugs? Well, this is just one of many examples that anything in the cardiovascular branch, myocardial infarction, stroke, leg amputation, and heart failure. As soon as the glucose increases, measured here as glycated hemoglobin, then the risk for the cardiovascular manifestation increases. And then it's then quite easy for a brilliant person to come up with the conclusion that if something increases and causes harm, the decrease must, of course, do them much better. And this was the initiation of a great number of studies. The very first one, actually with Bernie Zinman as one of the contributors, which showed that it was really worthwhile lowering glucose, was this study in people with type 1 diabetes, young people with diabetes. But as you can see, it took from 1923 to 1993 before this had been established. So it took a long time. And you can see here an example of macrovascular disease reduction by intense glucose control by means of insulin, as well as of retinopathy, microvascular disease manifestations. We conducted a study in people who were coming into our coronary care unit with myocardial infarction and diabetes, and we gave them insulin infusions very early, as soon as possible, and continued to treat them with insulin over the years. And you can see the first results presented here, a mortality reduction in the people who were intensively treated with insulin. And we have followed them up recently until, in principle, all of them are dead. And we could then see that the survival time, the 50% survival time, increased from 4.6 years in those who were treated conventionally to those treated intensively. So we prolonged the life for these patients with approximately 2.3 years. A caveat was, however, that by that time we didn't have statins, lipid-lowering drugs. We didn't have modern blood pressure-lowering drugs. We didn't use aspirin to these patients in any extent. So the only risk factor that we were able to control by that time was the glucose. And perhaps this was that made it easier to show that lowering glucose really made a beneficial approach. Since then, and as illustrated here, we have had an enormous development of different types of glucose-lowering drugs, ending up with the most modern, which you will hear more about later. But as you can see, there have been some intense research, and what about them? Did they help? The UK Pds study, which is a classic study, a paradigm-breaking study in its way, was performed in people with newly detected type 2 diabetes. And they investigated glucose-lowering drugs in the form of metformin, sulfonylurea, and even insulin, and were able to show a reduction of myocardial infarction and even microvascular diseases. However, again, by that time when this study was performed, there were no statins, no modern blood pressure-lowering drugs. So the fight was only for glucose lowering. And then perhaps it was easier to show something. Subsequently, a number of other studies, 3 of them illustrated here, called Accord, VRET, and Advance, tried to repeat the findings from these early studies and failed. They didn't really show any morbidity reduction or just a slight reduction of myocardial infarction, and actually in one of the studies Accord a slight increase in mortality rather than decrease. And if we summarize a number of early studies, they have a number of names like this. They were, some of them favorable in the beginning, neutral when we tried to repeat the Digami first study, and then we had a favorable study, proactive, and then safety concerns. And if we look at this, all studies performed when we didn't have anything else to give the patients were successful, but the studies who were actually performed with a supplement of other risk-reducing factors were less rewarding or even negative. So the discussion then went around on safety of the drugs. And if you want a side effect, you should take a glucose-lowering drugs. There is an ample number of them. Any drug has side effects. If the side effects are few and minimal, then okay, you need to treat, and it's the benefit is there. But one thing that concerned people very much was the cardiovascular side effects. It was assumed that perhaps they caused cardiovascular harm rather than anything. And this caused the FDA, the Food and Drug Administration, and the European correspondents to initiate rules that you have, if you have a new glucose-lowering drug, to prove cardiovascular safety. So many studies were performed where the traditional treatment was given to the patients, and then a placebo tablet or the new drug, and then studies over time to look whether they caused harm or not. And to get a drug in the market, they had to be shown to be non-inferior to commonly available previous drugs. A great number of studies are have been completed or are running just now, and presently about 120,000 patients are involved in these studies, enormous amounts of money, efforts, and research. If you summarize presented trials here with saxagliptin, with alogliptin, with sitagliptin, and with lixisenatide, you can say that they are all done in people with type 2 diabetes, either with cardiovascular disease already or a high risk to get it. The follow-up is relatively short because in the early studies it took maybe 5-6 years to show benefit. The endpoint are the common endpoint: cardiovascular death, myocardial infarction, and stroke, and no impact at all in these studies. They were non-inferior, but they didn't really improve anything. So why did the brilliant idea of glucose lowering fail? Well, there may be many reasons. One is this: diabetes is not only glucose, it's a multitude of things. It's a dysglycemic condition where you have a lot of things: endothelial dysfunction, dyslipidemia, you have pro-inflammatory activation, etc., etc. And if you only strike one of the risk factors or the components, it may perhaps be less rewarding. Another one is that actually the modern trials that were done to prove safety, they did really not lower glucose in different aspects between the different study groups. So if the drugs had an effect, it was not due to glucose lowering. It must be something else, a pleiotropic glucose-independent effect. And none of the shown drugs had such an effect. You will hear more about that later on. So we have a number of problems with the studies. They have short duration. They didn't really start good endpoints, perhaps. They cannot tell you anything about long-term effect. They were initiated by, rather than academic reasons, they were initiated to prove safety, to get a drug on the market, which is a legal or authority-applied type of research, which perhaps not always is the most smart. Still, there is a problem. This slide shows all patients with myocardial infarction in Sweden in between 1994 and 2014. And they are all below the age of 80. And as you can see, there has been a decrease in 1 year mortality successively over the years, and it's valid both for people with and without diabetes. But what you also can see is that people with diabetes has a constantly higher mortality after 1 year than those without diabetes. So there is a need to close the gap, which actually then many patients deserve a better life, a longer life. And then you have to ask yourself, is there any light in the horizon? And yes, there is. 3 studies, Sglt2 inhibition in the EMPA-REG, GLP-1 receptor agonist in LEADER, and SUSTAIN-6. They actually offer new knowledge and new hopes, and you will hear more about that in a minute. Thank you all for your attention.
Okay, well, good morning, everybody. It's a pleasure to be here. I'd like to thank the organizers and the Galien Foundation for really wonderful organization skills, hospitality, and if I could actually get this slide on. Perfect. So my disclosures are I work with many different companies that have developed drugs in this area. I don't own any equity or stock options. Some of you will think less of me because of that, but that's just the academic environment that we work in. And I actually work in the gut, which is an awkward place to start with, because most of us, when we think of endocrinology, we think of the thyroid or the ovaries or the adrenal gland or the pituitary. We don't really want to talk socially about what happens when we eat. It's awkward. We're only reminded of our gastrointestinal tract when it's not working. Either it's backing up or things are moving too fast or causing some distress. But nevertheless, that's what I do for a living. And it turns out that the GI tract is the largest endocrine organ that we have, with the greatest complexity and largest number of hormones. And I'm going to talk to you about a small number of these today. So although we don't like to think about the GI tract, it is, I think, the largest source of excitement for endocrinologists. So in 1983, I was handed this gene. This was at the early era of molecular biology, and I said, Drucker, you work on the glucagon gene. We knew what glucagon did. It was the hormone that opposed insulin. It raised your blood sugar. And I actually felt quite sorry for myself, because we didn't know what any of these other bits and pieces done here, GLP-1, GLP-2, had no actions for them. And we did very ridiculously simple experiments. And over the years, it turns out that this one gene, and everyone has their favorite gene. If I were to go around the room, everyone would give me an eloquent story for why their gene is the most important. But here's my gene, and this one gene has, I think, given rise to more drugs and more therapeutics to treat human disease than any other gene. Now, I'm sure somebody's reaching for their iPhone right now to tell me I'm incorrect and tell me about the drugs that come from their gene. But this is quite remarkable, I think, and illustrates a nice story that if you really understand human physiology and seek to understand what the hormones do, then you can exploit their actions for therapeutic benefit. So it wasn't always clear that GLP-1 would be something worthwhile pursuing. This is the first experiment we did in the early 1980s. We dumped GLP-1 on every cell and organ system we could find. We could get a little bit of insulin gene expression, cyclic AMP, insulin secretion. Didn't really think too much of it. Couldn't get it published, so that's why it's in PNAS, because we socialized with a member of the National Academy of Sciences in a way sufficient to move it forward. And that was published in 1987, so we're almost 30 years since that time. So why is GLP-1 a therapy for diabetes? So here's an example, a GLP-1 infusion in patients with type 2 diabetes. The glucose lowers, the insulin secretion increases, the glucagon secretion is inhibited. But notice what happens when the glucose returns to normal. The whole system shuts off. Insulin is no longer secreted. Glucagon is no longer inhibited. And that's because the GLP-1 receptor is a smart receptor. It shuts off its glucose-lowering properties when the glucose returns to normal. Now, you might take that for granted, but the insulin receptor is not a smart receptor, and that's why we have hypoglycemia. The sulfonylurea receptor is not a smart receptor, and that's why we have lots of hypoglycemia. So this receptor biologically does not promote its actions when the glucose returns to normal, and less hypoglycemia is a major feature of this system. So what could we do with this? These are studies from Rockman who showed that if you infuse patients with GLP-1, you could virtually normalize their glucose in a study setting. Now notice this is 1997, and we would have thought that all of the talent exemplified by many people in this room would have been working feverishly to develop drugs based on this mechanism of action. So here's a little bit of humility. It turns out the first GLP-1 receptor agonist approved for the treatment of diabetes was discovered by John Eng at the Bronx VA, not too far from here. And John purified this lizard GLP-1 receptor agonist called Exendin-4, EX for exocrine, END for endocrine action, and went around to all the pharmaceutical companies probably in this room and said, you know, I can use a peptide from the poisonous venom of a Heloderma suspectum Gila monster to treat diabetes. And everyone said, thanks for coming by, Dr. Eng, but we're really not interested. But nevertheless, that was the first drug approved. And we cloned this from the lizard. There was no lizard genome project at the time. I actually don't think there is a lizard genome project. And found out that the lizard has Exendin-4 genes and GLP-1 genes. And so it's a fascinating story. Now, why would you use GLP-1 instead of insulin? We've heard that we've had insulin for 95 years. And here's a plot of a head-to-head study, GLP-1 versus insulin, exenatide once weekly versus insulin. And where you want to be as a patient is in this area, in the bottom quartile, because in that area, patients are not only getting A1C reduction, glucose lowering, but they're getting weight loss. And almost every therapy up until this point in time, insulin, sulfonylureas, TZDs, lower glucose, but weight gain was unfortunately a side effect. So you can see more of the green dots with GLP-1 therapy get you into that sweet spot, which is both A1C reduction and weight loss. So today, as Lars mentioned, we have lots of DP4 inhibitors, lots of GLP-1 receptor agonists, and these have made a big difference for patients because they've enabled pretty good glucose control with much less hypoglycemia and either no weight gain or weight loss. And as a patient, those are very meaningful benefits. We have a large number of GLP-1 receptor agonists coming to market. They're all structurally different. They have unique PK, PD profiles. different modes of injection, different durations of action. And I'm not going to tell you about all of them today, but I'm just going to focus on a couple where we've had recent cardiovascular clinical trial outcome. So we heard from Lars that we would need something in addition to glucose lowering to perhaps combat cardiovascular risk. And here is what GLP-1 does. You can see that almost all of these actions on blood vessels, on the kidney, on weight loss, on inflammation, would predicted to be not harmful or maybe even beneficial for cardiovascular disease. And it also works directly in the heart. But a lot of this was from animal data or short-term clinical studies, so we didn't have the results of the large outcome studies. And this was the most recent study presented a little while ago last year that actually Bernie Zinman was one of the investigators on as well. And remember, these studies are designed as safety studies. The primary reason for doing this, as we heard, is to satisfy the regulatory agency's requirement for showing no harm. It's a big stretch up until this point in diabetes history to actually hope for benefit. So large randomized controlled clinical trial, standard of care. Even though this says placebo, the doctors and patients don't know what they're on, so they're encouraged to use as many other diabetes drugs as they can to have glucose the same in both groups. So what are the results of this? And you can see here now, unlike the data that Lars showed you, we're actually seeing a reduction in this composite endpoint of heart attacks and strokes and death, a highly significant reduction, really among the first to show, in addition to EMPA-REG outcome that you'll hear, that you can actually have a benefit beyond glucose that extends to cardiovascular mortality and death. And you can see the primary event that drove this very exciting result was cardiovascular death. And as the clinical trial folks in the audience know, death is a very hard endpoint. You don't really argue about whether someone is dead or a little bit dead if you're Monty Python. So this was a terribly important result for the clinical trial community, and also a suggestion that perhaps a trend towards reduced stroke, and also total MI, fatal and non-fatal, was also reduced with this GLP-1 receptor agonist. Now that's one drug in one trial. And I can tell you that up until the results of the second trial, we could say that there was no class of diabetes drugs which we would associate with reduced cardiovascular mortality. One drug and one trial is very exciting. It does not mean this is a class effect. So here we have a second GLP-1 receptor agonist, a once-weekly drug called semaglutide, in a much smaller trial design, only a few thousand patients, less than 1,000 patients in each arm, primarily studied again to show safety for regulatory approval. 2 different doses, a total of just over 3,297 patients in all 4 arms of the study. I would say that nobody expected in this much smaller, much shorter trial to have any hope of a benefit. We were wrong. Again, a highly significant reduction in the primary endpoint of MACE, driven by a reduction in non-fatal stroke. So MI is trending in the positive direction, but not significant. But if one looks at non-fatal stroke, highly significant reduction in this very small study, only a couple of years in duration. So for the first time, we can actually say that it's not just one GLP-1 receptor agonist or one drug, it's probably a class effect. Now, there's always the potential for something unexpected, and there was a slight excess imbalance of more diabetic retinopathy with this drug. These were transient cases in people with pre-existing retinopathy, but this will clearly need to be followed up in further studies to see if it was associated with rapid glucose lowering, as some people expect. So where does that leave us? I think the future, will be even more exciting, because we will now build as a community on the concept that GLP-1 receptor agonists can bring added value to patients beyond glucose lowering, beyond weight loss, but also encompassing cardiovascular protection. So you will see a lot of folks trying to improve upon this mechanism to bring broader benefit to not just patients with diabetes and obesity, but potentially for neurological protection, for non-alcoholic steatosis, and other indications. So really where we've come over the last 30 years is the development of a new class of drugs that we now have approved for the treatment of type 2 diabetes as well as obesity. And the primary virtues for our patients are a reduction in glucose, body weight loss, and these mechanisms are achieved with much less hypoglycemia. There is a little bit of nausea and vomiting with these drugs, a little bit of diarrhea, a small increase in gallstone events. There has been no sign so far of any malignancy or other major adverse event, but we'll keep an eye on this. It's been over 10 years since these drugs were first approved in April 28, 2005. However, for the first time, I think we can now say that this class of drugs is not only associated with weight loss and glucose control, but actually will save lives. You will have fewer heart attacks, fewer strokes, less cardiovascular death. And I think for our patients, which is what we all strive to do, this is a wonderful improvement in the quality of life and outcomes for our patients with these metabolic disorders. Thanks very much.
And I think we'll wait with the discussions until the end of the session and continue with Dr. Michael Mark, and he will discuss the clinical work on Sglt2. Please.
Thank you very much for this introduction, and it's really my pleasure, and I thank for the invitation to present here. And I try to get the same excitement across as Dan shared with you on the GLP-1s and DPP-4s, now on the Sglt2 inhibitors class. My disclosure was on the previous slide. I'm an employee with Boehringer Ingelheim, a family-owned company, so no stocks and shares in that one. And the story of Sglt2 inhibitors began in the 19th century, when French chemists had nothing better to do than isolate from the root bark of apple trees compounds and substances. And amongst those substances was fluorescein. And fluorescein turns out to be the blueprint for an Sglt2 inhibitors a century later. In between, they had a bitter compound which they thought could be reducing fever, could be good for malaria, and they tried it in several cases, and you see here a case report from a German doctor who treated a patient with a tumor, trying to shrink the tumor with this fluorescein, not knowing about the mode of action of that compound. In that patient, the tumor did not shrink. However, what they saw, he gained weight, good one, gained appetite, and that patient lost a lot of glucose in the urine, which you see on the bottom of that slide. The patient, the poor patient, was treated with 2 grams of fluorescein subcutaneously injected every day. So that was the beginning of the story. Fluorescein later on was tested in vitro, in vivo, in various models and principles, and turned out to have something to do with the kidney, have something to do also with the reabsorption of glucose in the kidney, not knowing about the exact transporters at that point in time. And many researchers, including diabetes researchers around DeFronzo, Rossetti, and Barbara Kahn, in that case, also published studies in pancreatectomized rats, where they saw that independent of insulin, fluorescein was able to lower plasma glucose significantly, and that gives us a good signal that could be worthwhile to be studied in type 2 diabetic patients. However, fluorescein as such cannot be used due to different limitations. Number one, the poor absorption, and it's not selective. And a metabolite from fluorescein is also interfering with glucose transporters, which are needed for the different cell types in the body. Second thing happened in detecting and defining familial renal glucosuria, which is a massive glucose excretion in the urine without the existence of elevated plasma glucose levels, so without the signs of a typical diabetic patient. These subjects turned out to lose massively glucose up to 170 grams per day. However, the other phenotype is not very remarkable, very benign. So with that, number one, a fluorescein, a blueprint compound, a tool compound, and second, also with the human disease link with this familial renal glucosuria, I think pharmaceutical industry had a perfect starting point for drug discovery and development. Meanwhile, in the early 90s, there was also the cloning of the S31 S32 Transporter. So we knew that in the kidney, glucose is reabsorbed via predominantly S32, but also via S31. So looking at the expression of the two transporters, it was found out that SGLT2 is more or less exclusively expressed in the kidney and there in the proximal tubulus, whereas SGLT1 on the bottom of that slide has also expressions in different other tissue of the body. Now let's look at the normal procedure of glucose handling in the kidney. Normally, in a non-diabetic subject, up to 180 grams per day is filtered in the glomerulum. And almost everything completely is reabsorbed in the proximal tubulus by the action of SGLT2 as well as SGLT1, two transporters which reabsorb glucose alongside sodium. That's the reason for the SGLT2 name, sodium glucose cotransporters numbers 1 and number 2. There are more existing in that family. Now what happens in a diabetic patient or patient with hyperglycemia exceeding this 180 grams per day? So there is a limitation in the absorption with SGLT1 and SGLT2, and there is then the remaining glucose is excreted with the urine. The SGLT2 inhibitors, they work especially at the proximal tubulus side, so glucose is filtered. Glucose is then not able to be retransported via the SGLT2 transporter and is excreted, and that's what we find, this excretion in the urine of round about 80 grams per day with an SGLT2 inhibitor. So if we look into that again, there is a correlation and a linear relationship between the filtrated glucose and the plasma glucose level. However, there is a so-called threshold for the reabsorption, and that threshold is around 180 to 200 milligrams per deciliter. Any glucose amount exceeding that threshold is excreted via the urine. In diabetic patients, the reabsorption capacity is increased via also the upregulation of SGLT1 as well as SGLT2. So more, up to 500 grams per day, is reabsorbed in a diabetic patient. So less glucose is then excreted. If we now apply an SGLT2 inhibitor, we lower the threshold for the glucose excretion. More glucose is excreted from the body, and we have a normalization of the glucose plasma levels. I mentioned already that the discovery development race between pharmaceutical companies started end of last century. And there were two classes of compounds available. First, with a blueprint of fluorescein, which belongs to the left-hand class, the so-called O-glucosides, and the now on the market available SGLT2 inhibitors, which belong all to the C-glucosides on the right-hand side of that slide. So what is the difference? There's only one molecule different. an oxygen versus a carbon atom. But that makes the difference. The O-glucosides are readily cleaved already in the gastrointestinal tract or then later on in the liver, so you would need very high doses, and I gave you the example of fluorescein up to 2 grams per day. Also other more modern O-glucosides had to be administered in a dose of up to 1 and 1.5 grams. Not so with the C-glucosides. And here's the difference, and we tested that preclinically, between an O-glucoside, remagliflozin, and a C-glucoside, empagliflozin. And what you see here, a more efficacious glucose lowering with a C-glucoside compared to the O-glucoside, that's number one. And second, also a longer duration of action due to the fact that the O-glucoside is readily cleaved and the C-glucoside is very stable. Now you see here the available, on the market available SGLT2 inhibitors, and they all belong to the class of the C-glucosides. Stable compounds, very similar, and what they have in common is a glucose moiety, which seems to be an anchor point to the Sglt2 transporter to really interfere and to bind to the transporter and inhibit the transport. Now, empagliflozin, as an example for an SGLT2 inhibitor, is a very potent as well as a very selective SGLT2 inhibitor, not interfering at therapeutic doses with other SGLT transporters. What we could see early on, that there is a dose dependency in glucose lowering with this empagliflozin in diabetic animal models, as well as there is an increase in urinary glucose excretion, also dose dependent. On the longer term, we see a glucose lowering with the fasting glucose levels dose dependently, as well as the long-term measure of the glucose homeostasis, which is the hemoglobin A1C, the glycosylated hemoglobin, which you see also dose dependently reduced on that slide. That was the preclinical work. Now, does it work also in humans? And what you see here is the first clinical trial with empagliflozin in type 2 diabetic patients, where you see that there is an increase in urinary glucose excretion with different doses of empagliflozin at the early day 1 as well as after 4 weeks. Now, that translates into beneficial aspects for type 2 diabetic patients, namely the consistent and significant glucose lowering measured in different clinical settings as monotherapy, as combination therapy with all existing anti-diabetic agents on that slide in a phase 3 clinical trial program consisting of more than 14,000 patients. And that number or the size of the clinical trials were mentioned earlier today. On top of the glucose lowering efficacies of SGLT2 inhibitors, they come with additional benefits, namely body weight lowering of between 2 and 3 kilograms, as well as a control and a lowering of systolic as well as diastolic blood pressure of about 2 to 4 millimeters mercury. That's all the same clinical data what we have with SGLT2 inhibitors. So what we can conclude is that SGLT2 inhibitors, as a modern class of anti-diabetic treatments, they correct a pathophysiological defect, namely the upregulation of the reabsorption of glucose in the proximal tubulus in type 2 diabetic patients. They also, beyond the glycemic control, come with benefits, body weight as well as blood pressure, and they have also the benefit of not causing hypoglycemias. On the long term, they reduce significantly and steadily the HbA1c, and they are, since they are insulin independent, also complementary working with any other class of anti-diabetic agents. So, summary, empagliflozin is a potent and selective SGLT2 inhibitor, and for us as a company, it took us 10 years from the earliest days of research to come to the submission of this compound and to bring it to the patient and to the markets. And it was not easy. In the early days, there was a lot of debates, pro and con, this mechanism of action causing deleterious effects on the kidney, That was the suspicion, but we always believed in that mechanism, and at the end, of course, we could convince ourselves and others with a wonderful compound as well with consistent clinical results. SGLT2 inhibitors are therefore very promising. They offer added value, I mentioned that, beyond the glycemic control, body weight, as well as the blood pressure control. Various SGLT2 inhibitors on the market do show comparable efficacies, although no head-to-head study is out yet. There are, of course, mechanism-related side effects that were mentioned. Due to the higher glucose concentration in the urine, you find first urinary tract infections and predominantly also genital tract infections, which are, of course, to be treated and can be treated relatively easily. Several compounds of that class are on the market, EMPA, DAPA, and canagliflozin in all the markets, in the global markets, as well as in Japan, different other members of this class. Beyond these effects, we studied carefully preclinically as well as clinical different other aspects of cardiovascular risk factors, and you see here on that colorful slide, yes, there is beneficial activity of SGLT2 inhibitors of empagliflozin on different cardiovascular risk factors functionally, and how they translate into cardiovascular outcome will be then the topic of the next talk. And with that, I'm at the end, and thank you very much for your attention.
Thank you very much, Dr. Mark, for this fascinating story. And we come to the last presentation by Dr. Zinman, also on SGLT2. Please.
Thank you, Bengt. It's a pleasure to be here in New York always, and also to take part in this very prestigious event. So just like all the other medication, SGLT2s showing promise still require a large cardiovascular outcome study. There we go. Perfect. Does it work? Perfect. Okay, and so my task is to describe some of the cardiovascular effects of SGLT2 and convince you that indeed we are in the midst of a paradigm change in the management of type 2 diabetes because of the results of some of these trials. Whoops, all right. My disclosures are shown there. Now, you know very well, this audience knows very well, that type 2 diabetes is a major risk factor for cardiovascular disease. Indeed, it's also a risk factor for all-cause mortality. And so when we're managing patients with diabetes, we obviously focus on eyes, kidneys, and nerves to reduce the microvascular complications. And as you heard, the Diabetes Control Complications trial set a new benchmark and established the primacy of hyperglycemia with respect to the microvascular complications in type 1 diabetes, which we believe applies to type 2 diabetes. What has been less clear, and Lars pointed that out very nicely, is the relationship between glycemia and macrovascular disease. Now, what is less commonly known by diabetologists like myself is that heart failure is now a major burden for patients with type 2 diabetes. Indeed, whether it's heart failure with reduced ejection fraction, and cardiologists like to use HFrEF, I like that term. If you have diabetes, your chance of being hospitalized with this and dying are much greater. And there's another kind of heart failure, HFpEF, heart failure with preserved ejection fraction, and similarly, no diabetes, diabetes results in a much worse outcome. And so, just like all the other drugs, that's a whole new industry out there, these medications, because people with diabetes have so much heart disease, the FDA in their wisdom said, you know what, we've had some bad experiences with thiazolidinediones. You need to show that your new diabetes drugs are cardiovascular safe? And that's mainly been the reason. And so empagliflozin is the first SGLT2 to undergo that kind of study. All these studies are large, non-inferior, event-driven cardiovascular safety studies on individuals with type 2 diabetes who are already at high risk for cardiovascular disease, because you want to finish these trials in a reasonable time frame, so you need individuals who are at high risk and are going to get a lot of cardiovascular disease. These are the other SGLT2 trials that will be coming to you shortly. So we're going to have a plethora of new data. So let me describe the results of this trial in some detail, because it was indeed the first diabetes therapy that was associated not with neutrality, but a remarkable cardiovascular benefit. All these trials are double-blind, randomized controlled trials. 2 doses of empagliflozin were tested, 10 and 25. And as you could see, patients had type 2 diabetes and had to have established cardiovascular disease. A1Cs were between 7 and 9. And we decided to choose patients that had to have at least an eGFR greater than 30. But there were some patients who really had significantly reduced renal disease, and I'll show you some renal outcomes if they had an eGFR of 35 or 40. Indeed, the label recommends a much higher eGFR when using these in clinical practice. And the study medication was given in addition to standard of care. And so here you see the standard of care that was applied. Patients were on background diabetes therapies. Their A1C was 8%. Most on metformin. Their blood pressure was reasonably well controlled. They had more than 95% on blood pressure lowering medications, and the majority of that blood pressure medications was ACE and ARBs. And indeed, they also had effective lipid lowering. Almost 80% were on statins. Some were on fibrates as well, and antiplatelet agents. If you have type 2 diabetes, have had a cardiovascular event, there's no question about the value of aspirin and then other antiplatelet agents. And so this is a study looking at the effect of a new therapy on a background of very good cardiovascular risk prevention. Now here you see some of the metabolic responses, and as Michael indicated, the value of these therapies are that they have different and desirable outcomes in addition to glucose lowering. Here's the glucose lowering effect. No change in diabetes medication could be done for the first 12 weeks, so that's the biggest effect. And then everybody tried their darndest to get the A1C as best as possible. Weight reduction with both doses, a reduction in systolic blood pressure, and low rates of hypoglycemia. So this was the first outcome trial showing a positive result. It's a little over a year, presented at the EASD. It's the first time I've ever been at a meeting where in the middle of the presentation was interrupted by applause. It was a remarkable event because I think the diabetologists were tired of hearing neutrality, tired of hearing, yeah, it's safe, yeah, it's safe, yeah, it's safe. And all of a sudden, now it's not just safe, there's a 14% reduction with empagliflozin in 3-point MACE. Now, the applause was followed by wow when they saw that the principal driver of this reduction was a 38% reduction in cardiovascular death. Now, Dan showed some slides with liraglutide where there is a reduction in cardiovascular death. It takes a little time to happen. Not the same magnitude, but a very significant effect of liraglutide. Here, the effect occurs very early. These two lines start separating, and they continue to separate. A very interesting observation, contrasting potentially different mechanisms of action with respect to a GLP-1 receptor agonist and an SGLT2 inhibitor. And when you look at cardiovascular death, well, for cardiologists, particularly those who've taken part in clinical trials, know there's a standard procedure. It's a committee that adjudicates cardiovascular death, and they do it in a very careful way, following a very careful protocol, and they're masked. We don't use blinded in diabetes trials. They're masked as to which treatment people are on. And you see sudden death, worsening of heart failure death, acute MI death, stroke death, and other death. They're all to the left side, but the biggest impact seems to be related to heart failure. So let's look at heart failure. Heart failure, as I pointed out at the beginning, is a real problem in type 2 diabetes. We saw that data showing the reduction in cardiovascular death as far as MI, sudden death, and we're paying a price. I mean, that's good. We move people along where they survive, but they also get a subsequent heart failure. And so here you have heart failure or cardiovascular death, and the reason we combine this is they're competing risks, and you see again a 34% reduction in heart failure hospitalization. This looks at hazard ratios or hazard rates over different times, and you can see this effect is very rapid, but sustained over the whole duration of the time. This is the effect with the 95% confidence intervals in blue. Now, you can also look at heart failure more carefully, and there are different definitions of heart failure. The adjudicated heart failure, investigator-reported heart failure, adjudicated heart failure or investigator-reported, introduction of loop diuretics as a surrogate measure of heart failure, and you see in every instance there's a significant effect of empagliflozin on reducing this outcome. And as Dan pointed out, the easiest, even an endocrinologist, you don't have to be a cardiologist to do this kind of adjudication. Mortality is a very robust outcome for any trial. Many trials do not have are not powered for this particular outcome. But here you see again all-cause mortality, 32% reduction, very dramatic. That starts occurring early, and these lines are continuing to separate. Safety is always a concern, and as you already heard, the major safety issue is genital infections, particularly in women. These tend to be treated with over-the-counter medications by the participants themselves. Uncircumcised males can get balanitis, but otherwise, remarkably clean safety profile. Diabetic ketoacidosis has been reported in patients who have been using this off-label in type 1 diabetes. We did not see that in EMPA-REG outcome. And volume depletion again has been reported with other SGLT2s, as well as bone fractures, all of which were not seen with empagliflozin. So how does this work? Unfortunately or fortunately, we have curious minds and we say, well, that's amazing results. If I knew how it worked, I'd feel better about believing those results. And so there are potential mediators of this effect can be listed here. There are glycemic mediators, vascular tone mediators, there are lipid mediators, adiposity mediators, volume mediators, and the way we measured these are shown here. For volume, it's hematocrit. Hematocrit does go up in these patients. They have an osmotic diuresis. And then there's others, uric acid goes down. You get uricosuria with these agents, and therefore you get a reduction in uric acid. And so there is a way of looking at this, and this is a univariate, this has not been published yet, presented at the ADA. It's a univariate analysis of potential mediators of empagliflozin on cardiovascular mortality, and we're looking at the updated mean for the particular variable, not the baseline and the study, but the updated mean. And if a variable had a big effect, it would reduce the outcome substantially if you adjust it for it. So let's see what happens. Volume as measured by hematocrit in this particular model accounts for 51.8% of the effect. A1C about 22, fasting plasma glucose 29. And if you look at the change in hematocrit, which is a measure of volume, you see a very, very rapid and significant increase in hematocrit that is sustained. It's very different than what you see with a thiazide diuretic. However, you need to be cautious about interpreting these kind of results. Number one, they're post hoc and therefore should only be considered hypothesis generating. Cardiovascular death has a broad definition, multiple subcategories and etiologies. Only covariates that are measured could be included. Example, we didn't measure BNP and we didn't measure ketones. There's some interesting hypothesis that the slight increase in ketones that occurs with an Sglt2 inhibitor may provide a preferred substrate to the heart and improve cardiac function. And then we need to do multivariate modeling. So the other quick thing I'm going to close with is kidney disease. As you saw, Sglt2 receptors are in the kidney. These are kidney drugs that have a dramatic effect on cardiovascular outcome, I believe, through a hemodynamic property. But if they are kidney drugs, we really should look at kidney disease, because in fact, diabetes accounts for a large percentage of kidney disease, of chronic renal failure. We know there's a relationship between chronic renal failure, impaired renal function, and cardiovascular outcomes, and so we did just that. And looking at EGFR, we see an interesting phenomenon. As expected, based on the mechanism of action, just like with ACE inhibitors, there's a brief reduction in EGFR, and then it stabilizes. With placebo, the EGFR continues to drop. Very, very significant changes. When you look at the most robust renal outcome, the one that the FDA likes the most, they don't like proteinuria, microalbuminuria, they like doubling of serum creatinine. And here you see the effect of empagliflozin in EMPA-REG outcome on the doubling of serum creatinine, and you see a very dramatic reduction in doubling of serum creatinine over the 48 months of follow-up, a 46% reduction. When you look at things like acute renal failure and acute renal injury, which has been a concern that these agents may cause it, you see a protection, actually, a reduction of acute renal failure, a reduction of acute kidney injury. So to conclude, in the EMPA-REG outcome trial in patients with type 2 diabetes and high CV risk, the Sglt2 inhibitor, empagliflozin, reduced all-cause mortality and cardiovascular mortality, heart failure burden, heart failure mortality. Empagliflozin slowed the progression of kidney disease and reduced clinically relevant renal events. Empagliflozin was well tolerated, but was associated with an increase in genital infections. Now, the Canadian Diabetes Association looked at this data. It's an evidence-based guideline, and they actually, this is the paradigm shifting, said, you know what? Most guidelines say metformin, and then they give you a menu of drugs that you're to choose from with pros and cons, which is terribly confusing for primary care physicians. So after metformin, the CDA said a priority should be given to Sglt2 inhibitors in patients who have type 2 diabetes and clinical cardiovascular disease. In other words, they fit the recruitment criteria for EMPA-REG outcome. If you have previous cardiovascular disease or you had a cardiovascular event and you have type 2 diabetes, you need to be on an Sglt2 inhibitor with demonstrated cardiovascular outcome benefit. Well, as of today, there's only one. It's called empagliflozin. And then they go on describing other treatments and should be individualized. So let me close by first of all acknowledging the fact that this was a very interesting trial run by an academic steering committee in collaboration with the pharmaceutical industry. So the steering committee is listed here. I had the privilege of chairing the steering committee. Christoph Warner is a nephrologist. John Lekeen is a internationally recognized biostatistician who worked in DCCT and GRADE. Dave Fitch is a cardiologist. Eric Blumke works for BI. Odd Eric, similarly, is work for BI. These individuals are BI employees. Silvio is an endocrinologist from Yale. So thank you very much for your attention.
Thank you very much, Dr. Zinman. Fascinating story. It really sounds that there will be a paradigm shift. And we are short of time, but I think we'll take a few questions. The audience, any? Before we have a question, maybe I can ask you, what do you think is a real or most important factor contributing to the decrease in the cardiovascular effects?
Yeah, so, I really think that when we look at pleiotropic effects, we've learned something from, for instance, the thiazolidinediones. They had tremendous pleiotropic effects. They did a lot of good things, decreasing inflammation, reducing blood pressure a little bit. But one of the things they didn't do well was with respect to fluid balance. Indeed, it's clear that they cause fluid retention, and it's clear that they precipitate heart failure. So I think a lot of people with type 2 diabetes are perhaps a little fluid overloaded, and I think that the value of the osmotic diuresis, as well as some of the other effects we just don't know yet, is probably so important that you see an immediate benefit for some patients. 10% of our patients had heart failure at baseline. May have been more that was undetected, but 90% did not, and still they benefited dramatically from this drug. So we don't know for sure, but I think it's a hemodynamic effect.
Okay, Dr. Rydén?
If you look back in time, I have not seen anything that rapid as with the Sglt2 inhibitors, but for when we first tried ACE inhibitors in heart failure, that is also an immediate impact.
Right.
So as soon as you interact with a neuroendocrine abnormal or pathological activation that is caused by compromised myocardial function, something happens rapidly. So I agree that it's a hemodynamic effect immediately. And then subsequently, I think that the other many effects which interacts with what I showed you, diabetes is only not glucose, it's many other things. And everything is interacted with. And the GLP-2 receptor agonist supplements that. And interestingly enough, I think that the impact, but Daniel, you have to correct me, they act differently and more successively. And for me, a trial with a GLP receptor agonist taking the slow-coming advantages into account and a SGLT2 receptor inhibitor would be an ideal study. So one arm with one of the drugs only, one with the combined drugs. We cannot do placebo anymore because these drugs impact mortality. And then perhaps you can take out the benefit, the immediate benefits, and the slow-coming, which presumably is regression of atherosclerosis or less vulnerable plaques that doesn't crack that much and cause, for instance, myocardial infarction. Dane, what do you think?
I think it's a great trial, and we do have some companies that either have alliances or within their own portfolio both drugs, and it would be wonderful for patients to see the cardiovascular benefits of the combination.
Okay, are there any questions from the audience, please?
Dr. Zinman, is there any biology theory or mechanistic theory about why SGLT2s cause genital infections?
No. So let me just repeat the question. The question is, why should you get an increase in genital infections with SGLT2? And so the simple answer may not be 100% correct. For years, as a medical student and as a resident, we were told, oh, you need to clear glucosuria. I mean, glucosuria is a bad sign for diabetes. Indeed, before they could measure blood sugar, it was a dip in the urine. And so here is an agent in which we're creating glucosuria. And it turns out that has dramatic benefits with respect to volume, with respect to A1C, with respect to blood pressure. But having more glucose in the urine simplistically can serve as a substrate for mycotic infections. Now, is it that simple, or is there more to it? Probably it's a little. There may be something else that relates to it. The fact that people with diabetes have issues with infection, but I think it's basically substrate. What do you think?
Okay.
Yeah.
We get microphone.
Thank you. If the hypothesis is correct that it's that the beneficial effect of Sglt2 on mortality is hemodynamic and mediated by diuresis, one might predict that more aggressive use of other mechanisms of diuresis would have a similar effect. Are there data consistent with that, or might there be some peculiar nature of a glucose osmotic diuresis that could have a separate effect?
Well, yeah, so that is really a great question, and I never say that the results are due to a diuretic effect, because I think it's more complicated than just a simple diuretic. And indeed, osmotic diuresis is very different than Lasix, for instance. The macula densa is actually blocked from sensing the changes in sodium that occur with Lasix, whereas it's not with empagliflozin. So what happens with respect to the kidney is intraglomerular pressure decreases. That's a very, very important direct effect. As more sodium and glucose go into the tubule, the macula densa says, oh, the amount of sodium in the body is fine. I can constrict the afferent arteriole into the glomerulus. ACE inhibitors increase the diameter of the efferent arteriole. So, we're studying now both of them. But, these patients were on pretty aggressive diuretic therapy, and we got this effect on top of that.
If you look at studies, cardiologists studies on diuretics, we are afraid of that. Actually, you activate the renin-angiotensin system by giving too much of diuretics, and we try to keep it down as much as possible. And there are no major studies showing that you have anything but symptomatic relief by diuretics. We need to use them because it's not nice to be dyspnoic or edematous, but you should use them with caution.
If I may add to that, with a diuretic you lose sodium and water. With an SGLT2 inhibitor, in addition to sodium and water, you lose also glucose with all the metabolic consequences. And I think there are hypotheses built on that which have to be proven, but there could be a clear difference.
So those who think that SGLT2 inhibition is an expensive diuretic are probably wrong.
Unfortunately, our time is out, and we're already 5 minutes late. So I guess we could continue for another hour. But I'd like to thank all of the speakers for fascinating presentations of a rapidly moving field with an enormous potential. Thank you very much.
Thank you.